Hello friends, welcome to Medicare Tab. Today we seeing topic is respiratory conditions. So in this what and all diseases, respiratory diseases and all we will see in these topics, and it will be like a basics. So upcoming video I will take a full disease videos all. Okay, and that time I will say about a disease and elaborate I will say. Okay friends, we will go inside a video. So first we will see asthma. So first asthma is definition is asthma is a condition in which a airways narrow and swell and may produce a extra mucus. So this is one of the conditions of the airway. So it will be narrow as well. It may be produce a extra mucus and all it will be produced. So what are the symptoms of asthma are SOB, chest tightness, wheezing, breathing through mouth, and anxiety. So these are all the symptoms of the asthma. And cardiopulmonary clinical manifestation. So what and all examination we will do? So first we will see a physical examination. In physical examination we will check vital signs and barrel chest and cyanosis and cough with sputum protections. Okay. In chest assessment findings, so we will do if we auscultate the asthma patient means we can hear wheezing and crackle sounds. So how we will find asthma and all? In PFT findings is that means the FEV1 and the FEC is less than 70, want to be less than 70%, and FEV1 is less than 80%. Okay. In chest X-ray we can see a flattened diaphragm and dark lung fields and all we can see. So what and all diagnosis we want to take for the asthma patient means patient history first we want to take, next spirometry and phenotest and peak expiratory flow rates. So this is the diagnosis of a patient, asthma patients. And what and all management will do means oxygen therapy, antibiotics, bronchodilators, IV fluids, and immunopenicillin. So this is the management of the asthma. Next, pulmonary hypertension. So what is pulmonary hypertension? It is a condition in which a BP increase within a arteries of the lung. So in the arteries of the lung, there will be a blood pressure will be increased. So this is the pulmonary hypertension. And what are all symptoms we can see in pulmonary hypertension means SOB, syncope, chest pain, swelling pain, tiredness, and fatigue. So these are the symptoms of pulmonary hypertension. And how we will manage means INO and supplemental oxygen. So we can manage pulmonary hypertension through this. Next, bronchostatic, bronchiectasis. So what is bronchiectasis? So it's an abnormal, irreversible dilation of bronchi caused by obstructive and inflammatory changes in airway walls. So if you see means it's a healthy airway. So when a bronchitis it can means it will be a mucus and dilated airway you can see here. So now we will go to symptoms. What are the symptoms means cough, SOB, wheezing, sinusitis, and fatigue. And cardiopulmonary clinical manifestation. So what and all we can examine clinical manifestations? In physical examination, vital signs, and use axillary muscles of inspiratory and expiration, and barrel chest we can see, and kinosis we can see, and digital clubbing we can see. In chest assessments, what and all we can in auscultation, what and all we will hear means hyperresonant percussion note, diminished breath sounds, rhonchi or wheezing, and bronchial breathing sounds and all we can hear through auscultation. Yes, how we will diagnose? We can diagnose through a chest X-ray and CT. And how we will manage means in general we can manage by control pulmonary infections and airway clearance by chest physiotherapy and postal drainage and cough manure and humidification. So pharmacology we can manage bronchitis by the antibiotics, inhaled fluoroquinolones, that is ceprofloxacin and dry powder mannitol and hypertonic saline. Next, we will see about employment. In employment model, we will see means definition, etiology, stages, signs and symptoms, complications, and management. So, first we will see what is employment. Employment is a collection of pus in the space between the lung and the inner surface of the chest. It's also known as pyothorax or purulent pleuritis. So, employment means there's a pus will be collected in the space between lung and inner surface of chest wall. So, here you can see there's a pus collections here. So, this is a employment. And etiology, what under etiology means parapneumonic, post-trauma, post-surgery, subpneumic abscess. So this is under the etiology. Most commonly it is a parapneumonic. Next there is stages. So first is acute stage, that is acute stage. We'll see. It's approximately in 7 days and pleural filled with a thin serous fluid that slowly relatively low white cell count. So first it will be may appear in first 7 days, and that time it will be a pleural will be fills in the like a thin serous fluid. So it shows a little low white blood cells count. Okay, and visceral pleura and underlying a lung remain mobile. And visceral pleura and underlying a lung remain mobile. Next transitional stage, that is fibrinopurulent stage. So this starts from day 7 to day 21. It is a higher white cell count and lung movement became increasingly restricted. And empyema fluid now becomes more thicker and turbid. So it will start from the day 7 to 21. So that time what will happen means higher white cells count will be there and lung movement will be increasingly restricted it will be, and empyema fluid are now becomes a more thicker. So next organizing, that is chronic stage. So in this how means it starts from 21 days. After 21 days, usually 4 to 6 weeks. So inner layer shows inflammatory cells and draw the ribs through weather, producing a chest deformity, later lead to fibrothorax. So what under risk factor means neoplasm and drug use and HIV infections. These are all the risk factors. And signs and what under signs and symptoms are fever, cough with expectoration, and pleuritic chest pain, and dyspnea, loss of weight, and night sweating will be there. And what are all complications will be there? Rupture into the lung, that is bronchopleural fistula, and septicemia and septic shock will happen, and spread to the subcutaneous tissues. Diagnosis will see means LRTA, possibility of complicating emphysema, and history and physical findings are suggestive, and chest X-ray, CT and ESG we can diagnose. And what is the goal of treatment means? First treat the infections. Next you want to drain the pleurine deficient adequate and completely. Next you want to re-expand the lung to refill the pleural space. Next antimicrobial. What under antimicrobial we can give means clindamycin plus penicillin and pneumococcus, and antibiotics are chosen based on the culture results we can give. Next we will see a pleural efficiency. So pleural efficiency is a excessive fluid accumulated in the pleural cavity. That fluid filled space is surrounded by the lungs. So pleural efficiency means as a fluids that is accumulated in the pleural cavity. You can see here the fluid is accumulated in pleural cavity. So the filled space are surrounded by the lungs. Okay. And what under etiology means viral infection, that is a flu, and fungal infection, and lung cancer near pleural space, and bacterial infection such as pneumonia, and autoimmune disease, that is rheumatoid arthritis. So this and all the etiology. Next, what are all risk factors in pleural effusion means chronic heart failure, tuberculosis, pulmonary embolism, cancer like lung, breast or lymphoma cancer we can happen, and nephrotic syndrome, and pregnancy, and connective tissue disease, and liver disease. So these are all the risk factors. There are two types of pleural effusion: transudate effusion and exudate effusion. First, we will see transudate effusion. So they rise from CHF and nephrotic syndrome and peritoneal dialysis. So what are the characteristics of transdiet efficient means it occurs primarily in non-inflammatory conditions and it's a low protein, low cell counts in fluid and the pH will be a 7.40 to 7.55. So in exudate efficient, in exudate again we can see in exudate efficient it can arise of tuberculosis, emphysema, bacterial and fungal pneumonia will happen and pancreatitis will happen. So what are the characteristics of exudate efficient means it's often turbid or purulent and pH is less than 7.30 and it's a high protein fluid. What are signs and symptoms of pleural effusion means pleuritic chest pain, fever, chill, and dyspnea and coughing and decreased or absence of breath sounds. Next, what are the complications? A large effusion could lead to respiratory failure. Next, diagnosis of evaluation. Chest X-ray, CT, chest and ultrasounds. This and all we can see. Treatment. What all treatment we can see means chest tube, remove of fluid, diuretics, and antibiotics. Next, pulmonary edema. So, what is pulmonary edema? It's a condition caused by the excessive fluid in lungs, and it is usually by a heart conditions also. So, if you see, means normal capillaries. If this is, you can see a fluid is filled in that capillaries. Next, we'll see the pathophysiology. So, it is an imbalanced stalling process. So, what and all means? Increase of pulmonary capillary pressure, decrease plasma oncotic pressure, increase in negative interstitial pressure, and lymphatic obstructions. Next, there are two types of classifications. First is cardiogenic and non-cardiogenic classifications. So, in cardiogenic pulmonary edema, it's a pulmonary edema due to increase of pulmonary capillary hydrostatic pressure and secondary to elevated pulmonary vein pressures. So, first it will be increase a pulmonary capillary hydrostatic pressure and it secondarily it elevate to the pulmonary venous pressure. So, a left ventricle systolic and diastolic disinfection and a left ventricle volume overload and myocardial infractions and cardiomyopathies. Cardiomyopathies. Next, non-cardiogenic pulmonary edema. Say head trauma, overwhelming sepsis, and overwhelming aspiration and smoke inhalations. Next, signs and symptoms are dyspnea, wheezing, anxiety, restlessness, excessive sweating, and cough. It's a fourth year pink sputum will be there. And what all treatment we can give means diuretics and anti-anginal drugs. And supportive care means oxygen therapy we can give. Thank you, friends. And I want to say thank you for Sweta and Naina to give a presentations for me. Thanks both of them. Okay, friends. Subscribe our channel. I think you like this video. Okay, you're doing one subscribe will for me motivation for me. So if any mistakes there means comment me. Okay, thank you friends. Bye. Have a great day.